onto the presentation. There will be, if any questions people would like to ask, if you put them in the question box, and then we will deal with those after the presentation. Okay, Jamie Ray, over to you.
Thanks very much. But yes, please feel free to put things in the chat as we go. Although, fair warning, I might not be able to see it. So if you want to speak as well, please feel free to raise your hand. There will be a few times during the presentation where I might ask for some interaction around raising hands to answer questions. So just be aware that I will be asking. So I'm a consultant in public health and I work at the County Council today, and I'm here to talk to you about infection prevention and control and how it's linked to vaccinations. The well-being of clinical staff is really important, and I want to take you on a bit of a journey in the next 30 minutes. So I just want to start with telling you a little bit about why the council are involved in infectious diseases. We have a role to play because we're responsible for ensuring the system is ready to respond to infectious diseases and environmental hazards. The Director of Public Health has existed since 1848, so that's 177 years of trying to stop people getting preventable illnesses. And at that time, when that role was formed, 273 out of 1,000 children born would die before the age of 5. Right now, it's less than 4 out of 1,000, so we've made some really significant gains. Modern epidemiology, which is the public health name for disease detective work, started here in England in 1854, so 6 years after the Director of Public Health role was created. And the discovery that cholera could be linked to specific water pumps in London revolutionised our understanding of why and how people get sick. So at this time, we're still recording all of the deaths, and our colleagues in business intelligence still do all the birth and death registrations within the council. So if you ever do want to see any of these statistics, you still can. And we do look at what people die from in the same ways that we did them. Around the same time that cholera was discovered, Florence Nightingale was on her way to the Crimea, where the nurses found inadequate medical records and huge numbers of sick soldiers. With no systematic recording or reporting, hundreds of soldiers were being buried with no record being made of their deaths. And we're really kind of obstructed from spotting obvious flaws in the system. And the truth that she uncovered was that 16,000 of the 18,000 deaths were not due to battle wounds, but due to preventable diseases spread by poor sanitation. So, of course, as time went by, the UK went on to make microscopes and take part in lots of specialist research. And we've come a really long way since barber surgeons would pull your teeth out and give you a cutthroat shave, probably not even cleaning their tools in between their clients. All the time, and hospital staff didn't realise that they were transmitting strep infections to new mothers and their babies, resulting in fever. So again, at that time, it was a case fatality rate of between 1 in 4 of people who contracted it. And 8 of the important rules for birth attendants from that time included such revolutionary advice as hand washing before attending a woman in labour and not going directly from an autopsy room to the bedside. So I suppose the ultimate thing I'm trying to get across is, what was it that made the biggest difference truly? It was clean water, sanitation and vaccinations. And those interventions are the backbone of what we know about infectious diseases. As time's gone on, it's got more complicated, and we have tips and landfills, incinerators, water treatment plants, and of course all the farmers and factories which grow, manufacture and package our food. And the challenge for the Director of Public Health role and myself in the council is that we need to keep looking at how we can protect people from as many infectious diseases and environmental hazards as possible. So in my role, somehow, I get to touch on all of this. So some risks are not avoidable and some we will never see coming. So big outbreaks still take place. The earthquake in Haiti in 2010 caused a cholera outbreak, which led to 80,000 cases and 10,000 deaths. We had a global pandemic of the coronavirus. And prior to 2019, I had worked on some strains of COVID, but this completely changed the world. And some autoimmune diseases are increasingly being linked to viral triggers. So the mass event of infection with COVID means that we're learning a lot more about how long-term impacts of viruses can affect things like neurology. The University of Exeter has found certain types of bacteria are associated with better memory and attention, and others are linked with poor brain health and Alzheimer's disease. So there are very many things which are being learnt about viruses in particular, but also the good bacteria which live within and on our bodies. So I work with environmental health. For example, since summer 2025, we've had 41 cases of botulism from aesthetic procedures across the UK, and tourism remains a significant source of possible infections. There are occasional outbreaks of food-linked illness. I will just mention briefly, in Florida in 2025, there were 21 people who drank raw milk. 6 of those hospitalized were aged under 10 and with severe complications in at least 2. So again, we can't even take for granted that food safety is always there. But today I'm here to talk to you about how infection prevention and vaccination are linked. So I know vaccines are a big topic, but I hope you'll be honest about what you think and that you'll let me answer any questions that you have. And leading on to this, the biggest annual hazard we face in the UK and Warwickshire is winter. So I've got a little Mentimeter quiz. If anybody's got a mobile phone, you can scan that image and it should take you to a little questionnaire. Basically, the question's probably going to be, how confident do you feel about having conversations about vaccines? That's the first question I'd like to ask. And then the second question will be about what winter means to you. So has everybody got access to, or can everybody see the image? I'm just checking.
Yeah, we can see it.
Brilliant. I haven't got any yet, so I'll just wait for a minute. Well, it's really good to see. I mean, what I can do is tell you that basically there's most people saying that they feel extremely confident or very confident or moderately confident in having conversations around vaccines. So that's a really good sign. The next question is basically asking about what winter means to you. So it's just 3 words about what winter means to you in the context of the NHS and in the context of your roles. So I'm just sticking it up on the screen so you can see what everybody's saying. But yes, cold, dark, miserable, viral illness, cozy, cold, safe, respiratory outbreaks, busy, busy, busy. And that pretty much reflects what I would say happened last winter from my perspective as well. So if I just go to my next slide, this was the weekly hospital admissions for flu. The last year, the peak happened between Christmas and New Year. So for the Warwickshire population, this equated to around an increase from 24 admissions per week in early December to 86 admissions per week by the end of the month. And when considering other winter respiratory illnesses, not just flu, that's around 100 people per week being admitted to our acute providers in Warwickshire between Christmas and New Year, which is not a very joyful Christmas for all of our staff across health and social care. When the rates are high, more staff are also unwell, leading to reduced cover. So in a pandemic exercise, we would expect between 15 to 20% of staff to be off in the peak of a pandemic. So that's around 1 in 5. So again, has a significant impact on workload. Flu is one of the trickiest things to deal with, and the main reason for this is that it changes every year. So just like one time your cold will give you a headache or another time a sore throat, a snotty nose, a fever, the flu is always circulating globally and changing and adapting to the places it finds itself and the people it infects. So Australia have just come out of their winter, and every year the flu vaccine is developed based on the strains which our Australian neighbours have been seeing. This gives us the best chance of being protected from the common strains that we know about. Of course, a novel flu strain can evolve, which may be different. So you can catch the flu in the year that you've had the vaccine. It might be a new flu, but the flu vaccine is the best information we have on what you're likely to see out there in the world based on the evidence we have. And this vaccine is proving to be effective, but it's only one piece of the puzzle. So now I was going to do a quick quiz. So this is one where I would ask you to raise your hands. I'm going to start with my animal flu quiz. So who here thinks that horses can get the flu? Put your hand up or raise your hand or react if you think yes. Okay, we've got one person saying yes, they think horses can get the flu. 3 people. Well, you 3 people are correct. Oh, Theckley has agreed as well. Yes, you're all right. Horses can get the flu. What about cats? Who thinks that cats can get the flu? Okay, a lot of people are immediately in with that one. I think cat flu is definitely a lot more well known, but yes, cats can also get the flu. Next one, birds. Can birds get the flu? And reassuringly, everyone's got their hands up for that one because yes, bird flu is a thing, and it's something that happens in Warwickshire quite a lot. Staffordshire-upon-Avon Council in particular have a lot of dealings with people talking about bird flu. So again, something that's very prevalent in our area. Also, the only recorded death from bird flu last year was at a farm in Shropshire. So again, you know, bird flu is definitely one that we do keep an eye on. Next, pigs. Who thinks that pigs can get the flu? Oh, 7, 8. Yep, well, clearly the memory of swine flu is with you all, so that's good because yes, pigs definitely can get the flu. And then finally, we've got bats and whales. So I'll start with bats. Who thinks that bats can get the flu? Still a few hands, but not everybody. Oh, not as many people as for pigs and for birds, but you are right. The bats can get the flu. And then finally, whales. Who thinks whales can get the flu? Less people. Well, it was actually a trick quiz because everything on that list can get the flu. So whales, cats, birds, pigs, horses. Obviously, not all of them are transmissible to people. I would say that the ones that are the highest risk are probably going to be birds and pigs because birds, there's often a lot of people who live in very close proximity to birds, specifically in Asia a lot of the time, but also people who work in large-scale factory farming. And then also pigs, of which, again, some of the farms in some parts of the world are absolutely massive. We're talking, 10,000 pigs on one farm. So again, like the risk of a pandemic flu evolving in a stressed population of pigs is quite high. So anyway, moving on to my next slide. Oh, sorry, my mouse has gone to sleep. Oh, so at this point, I'm just going to talk about the cycle of infection. So the star of the show is normally the infectious agent. So that's the specific bug that's got someone down. And that could be anything, a virus, a bacteria, or a fungus, or a tapeworm, or a ringworm. So going over reservoirs, there are some places that are more likely to harbour specific types of infectious agents. So you could have a snotty tissue from a flu case, or a damp pair of slippers with athlete's foot, which is a fungus, some undercooked chicken with salmonella or E. coli, and of course people, because around 1 in 8 people carry MRSA harmlessly. And there are people who live with cold sores, which is a virus. The chickenpox virus can also live in our bodies and reactivate in later life, causing shingles. But of course, this is where the portals of exit and the modes of transmission come in. So are we spraying viruses around by sneezing? Are we feeling better but still excreting some bacteria in our poo? An underrated one would be cuts. We see more and more that people with ulcerated wounds struggle to heal, and bacteria, which can be completely harmless to most people, can be quite serious on an unhealed wound. But then, of course, there come the really important bits for us working in healthcare. You've got your portals of entry and the susceptible host. And I think this is sometimes where we don't spend enough time. Viruses in particular are opportunistic and clever. They hide in our own cells, and it's the job of our bodies to fight them off at the end of the day. A person has various ways a germ can get in, and this is important. So as well as how much snot was sneezed in your face by that toddler, how often are you touching your face without thinking? What do you eat? How is it cooked? Do lots of different people around you have the flu? Meaning there's lots of more of it around in the air in the form of droplets. And then, of course, you have your individual circumstances. So are you well nourished? Have you been sleeping well? Do you smoke? Do you have any vitamin deficiencies? And there is actually some evidence that vitamin D can be a factor in winter, where we're no longer getting active vitamin D from sunlight due to the tilt of the earth away from the sun at this time of year. Vitamin D can also be a factor in osteoporosis in older women, meaning that they may faint or fall or be more likely to end up in hospital, where again they're at higher risk of infection from other sources. Do you have cancer, diabetes, heart failure? Are you a newborn baby? Do you have an elderly relative? All these factors play a role in how likely you are to get ill and the kind of risks you'll be willing to take. It's not as simple as somebody sneezes on me and I get sick, although sometimes if it's a particularly nasty germ, I'm thinking norovirus here, it's got a very low infective dose and it's quite difficult to avoid catching it once it's been around. So why is vaccination so important in the chain of infection? So I wanted to just show a quick video here, which the people who've been in the meeting may have seen before, but hopefully you can hear this.
So here, this is a diagram where each dot represents a person, with all representing the connections between these people.
Just to confirm, can you hear my voice on that?
Yes.
Okay.
Now what we're going to do is colour in the dots to show 80% of people are vaccinated. Now, as you can see here, the 20% unvaccinated people are still white, and they are distributed equally among the network. Now, we are going to map the fastest chain of transmission, or the longest chain of transmission in an outbreak. And as you can see, it equates to around 15 people, which isn't very large. So now what we're going to do is look at the same image again, but in this time, the 20% of people who are unvaccinated are all going to be distributed differently. Now, if you can see at the bottom right, there is a clustering of people who are unvaccinated in the yellow circle. Now, looking at this map with exactly the same coverage, the maximum length of outbreak transmission is around 90 people, which is significantly larger than the previous example.
So again, that's just to demonstrate to you that the changes that can be made simply by vaccinating in different ways. So again, the best example of that is probably going to be measles, right? Measles is so infectious, it's really, really catching. But if you have a group of people who don't vaccinate, who are all clustered, which they usually are, because it will be along well, kind of philosophical, cultural, or perhaps religious lines, basically that means that clustering means that the outbreak can spread further when it goes outside of that community. So speaking specifically about flu, because I am here mainly to talk about winter, all these people are eligible for the flu vaccine, and the staff vaccination programme is just one part of the puzzle. So we vaccinate different groups because they're important in the chain of transmission. So little kids can give the virus to their older relatives, who then pass it to schools. Care home staff, especially those that are moving between areas or sites, are potentially taking infectious viral illness with them. So again, it's like different bits of the system all play a part in trying to reduce that larger chain of infection. Again, the flu vaccination is offered annually because, again, I just want to emphasise, we don't know every year which strains will be circulating. The inactivated flu vaccine does not contain the live virus and it cannot cause flu, but the flu spray, which children have, is a weakened version of the flu virus, and it's a slightly different vaccination. Now, just to be very clear, vaccines aren't everything. They're not a replacement for good hand washing in particular. They're also not always injected anymore. So I've mentioned the flu spray for children. So again, it's just less traumatizing for the kids to just have a little spray up the nose and both nostrils. They've got the oral polio vaccination, a rotavirus vaccination for babies. And at the moment, there's actually new research being done in topical vaccines. And they aren't always a magic bullet, although sometimes they're really close. So again, like measles, it's best to have 2 vaccinations for measles. That will give you lifelong protection. But a single or even 3 or 4 different whooping cough vaccines throughout your lifetime, you may still wane in your immunity against whooping cough and still need a booster. Same as with tetanus. So again, some vaccines are really effective and give you a really long span of immunity very clearly, such as measles. Other ones, such as flu, are only best within the year that they've been created because of the strains that are circulating. So I'm just going to go back to basics now and just talk about the different terminology you might hear around vaccination. So you've got the vaccination, then you've got immunisation. So immunisation is the process of becoming protected. So the immune response, which comes following a vaccination, which is the intervention that we give. And then, of course, some groups are more susceptible to infection due to their immune response. So people like COPD or asthma, they can be significant in winter respiratory viruses. But of course, when we talk about people who are likely to become unwell, we would use the term clinically vulnerable. The key messages about all vaccines is that they are the most effective public health interventions available, and they're designed to protect you from serious illness. So they provide protection for wider communities and also contribute to eradicating diseases and preventing outbreaks. They're also monitored, so you can report side effects from any vaccine through the yellow card scheme. And it is generally accepted that some vaccines have side effects which are mild. And the benefits of vaccines are that we're not off work looking after poorly kids and worrying about our old relatives catching something preventable. So aware that everybody here has said that they feel very confident, this is from a motivational interviewing sort of dispelling myths information. So I'm here primarily to talk about how we talk about vaccines. So this is how to make it simple. They teach your immune system how to create antibodies to protect you from diseases. So those are special cells that protect you from these diseases. They're then stored in the memory vault, which again, for the general public, is a much more understandable way of looking at it than thinking about all the different immune memory cells that we have. When they come across the disease in the future, those memory cells quickly identify the disease, make more of themselves so that they can kill it. It is much, much safer for your body to learn through vaccination than through catching the diseases. And your body knows how to fight the disease and can offer give you protection. So again, thinking about the safety of vaccination versus wild type, if I go for again the example of measles, in measles, if you catch measles in the real world, then you can have immune amnesia for up to 2 years afterwards. So your immune system actually destroys the memory cells that you have from previous infections of ear infections, colds, all the rest of it. So for the 2 years following a measles infection, children are more likely to catch lots of other stuff. So again, if you have the measles vaccine, that won't happen. That will not happen. But if you catch natural measles out there in the real world, then that will happen. So again, it's much, much safer to get it through a vaccine than it is to get it through real life infection. Now, this is just a very quick little video that I was going to show you about the reality of whooping cough. So I'll just push play.
What if
Oh, it's going to do me an advert. Sorry about that.
And could earn up to 4.
You're just kind of happy. Uh-oh. There we go. Okay. It's okay. Okay, take a bath there, honey. Come on. Almost there. There we go. Oh my. It's okay. It's okay.
Anyway, I'm going to just stop there and be like, does anyone have any thoughts on the video? Because usually I think it's quite... Yeah, does anyone have any thoughts on that video? Liz?
Well, I mean, it's hugely distressing, isn't it? And I don't know, but I remember having whooping cough when I was about 6 or 7. It wasn't as bad as that, but I do remember that not being able to stop to cough, and then that as it came up. So I can't understand why people want to prevent their children catching that, really. But you lose the memory because nobody really sees it as much in this generation because everyone got vaccinated. So, yeah.
I do think those 10 deaths last year have made a big difference. I do think a lot more people are worried about it. Sorry, anyway, Tim?
Yes, I mean, I was working in hospital paediatrics in the late 80s, and we saw it, as long with measles and as well. And I think that there's probably a degree of complacency has developed within the population because they just haven't seen it or haven't had relatives with it or haven't had their own children with these conditions. So the importance of vaccination has sort of decreased in the collective memory, really.
No, I think that's true. And especially since COVID, there's a lot more people who are willing to question vaccines of all description, not just the mRNA vaccines. And again, I mean, I don't think that we should question any of them. I think they're all great, but it is interesting. Carolyn, sorry.
Yes, heartbreaking, and it makes me angry to think that parents will take the chance of putting children through that and all the other diseases when it's not necessary. Thank you for showing that, although it was really, really upsetting.
Yeah, no, I paused it quite quickly. I find it very distressing to watch, and I do this training session a lot, but it's horrible having to look at the poor little baby not being able to breathe. Oh, no, don't do that. Sorry, I'm trying to go on to the next screen, but it's not letting me. Oh, there we go. So when having conversations about vaccination, I suppose these are the tips, the do's and the don'ts. So providing and signposting information to correct decisions, being open to the conversation and respectful. We find that across staff in particular, they don't like being told about how they should get vaccinated because they think it's their personal decision, which it is. But again, I think that we need to get better at having these conversations and kind of gently challenging each other to really think about why we might choose not to do something like a seasonal vaccination like flu. highlighting the risk of becoming seriously unwell. And I think that, again, when it comes to flu, people forget how horrible it is to have that full-on 10 days worth of feeling like absolute rubbish, where you wouldn't even pick a £50 note up off the floor. If you saw it on the ground, you'd just rather lie in bed and feel better. But again, trying to avoid misinformation and making assumptions about people's beliefs, because most people are hesitant rather than anti-vax outright. The top 3 drivers of uncertainty in staff, though, are worries about side effects, not sure that it makes a difference, and also not wanting to be pressured about their health choices. So, I mean, I want as many people as possible to consider getting vaccinated. And so in the spirit of open, honest dialogue, I should address these issues head on. So this is the current vaccination rates for the most recent data that I have for the last season. So you can see that the health sector group that has the highest uptake is GP, and even that's gone down quite a lot between 2023 and 25, from around 60% to around 50%. It's even lower in mental health trusts and acute NHS trusts, and our local trusts have had variable uptake. And again, part of it is to do with how you get staff access to vaccination. From social care, this is the social care data that I have, and residents have got great uptake, generally speaking. We have a lot of people aged over 65 who are taking up the flu vaccine. Unfortunately, it doesn't work as well on them, and the staff aren't really. So it's only 12%, 12.7% of staff who are taking up the flu vaccine are older adult care homes, and even less in the younger adult care homes. So again, thinking about if it does make a difference, I mean, I'm showing this graph again, but it does make a huge amount of difference, because they prevent up to half of all the flu cases. So in any one year, you know, there could be up to 600 deaths in the UK, but it varies. Sometimes it could be only 83, and up to other years where it could be 1,500 people who are dying. And again, the flu vaccine's effectiveness, it works better in some years than others because of what I've stated previously about Australia taking the strains. It's not understood well why flu vaccines don't work so well in older adults, but it reinforces the importance of vaccinating children and healthcare workers, because again, that's just one part of the picture. But vaccines aren't just about personal protection, they're about protecting the whole community by reducing the burden of disease. I did include this very quick patient story, which is just somebody who never really got the flu vaccine because they didn't think it was that serious. But at the same time, you know, still feeling ill about 6 weeks later, completely debilitated. And ever since then, they've been like, yes, 100%, I'm going to have the flu jab, because if I can avoid doing that again, I will. And I think that for a lot of people, it's that personal story about why you should have it that can make all of the difference for people actually taking up the vaccine. I just wanted to briefly take a little tour into antibiotics and how they're related to vaccination as well. So I'm sure that you're all aware of antibiotics. They were discovered in 1928. There was a rotting cantaloupe that was found in a market in 1941, which was the cantaloupe which had the strain which ended up becoming penicillin on the mass production scale. They became available in the UK in the 1940s. And the risk of a woman dying in labour is between 40 to 50 times lower than 60 years ago as a result of this intervention. And deaths from scarlet fever fell from around 4,000 a year in 1900 to less than 20 only 50 years later. So resistance to antibiotics has been identified since antibiotics have been around pretty much. You know, from 1960s at least, we have seen that there are definitely going to be consequences to us using antibiotics, like resistance. So how are AMR and vaccination connected? The first way that they're connected is they reduce the incidence of bacterial infections. So if you vaccinate for a bacterial infection, there's no need to use the antibiotics to treat it. So that's the first one. Second one is it stops the secondary infections following viral illness. So during the Spanish flu in 1918, the main cause of death on death certificates was actually bacterial pneumonia, not flu. This is one of the reasons that Robert F. Kennedy thinks that flu doesn't exist. Obviously, I don't think that. I think that it's just a secondary infection following a horrible flu. But at the same time, by having the vaccination in the first place, you reduce the chances that somebody will get a secondary bacterial infection and then require antibiotics. Protects those who can't be vaccinated. And again, that video was a very young baby. And parents, like, you have to get vaccinated in pregnancy in order to protect the baby when it's under 6 weeks old. Maybe they missed it. Maybe there was nobody around. But again, like, there are always going to be those really vulnerable members of the population who can't be vaccinated because they're on chemotherapy, they have cancer. So again, we are going to reduce the amount of antibiotic resistance by making sure that they're vaccinated and therefore not needing antivirals or any of the other medications to treat them. And then finally, it reduces prescription of antibiotics for viral illness. And we know that if GPs don't prescribe as much, then people don't think it works. Because if you go to the GP on day 3 of a viral infection, and then you have antibiotics for day 4 and 5, you think the antibiotics are the reason that you got better, when actually you were already on the up. So obviously I'm saying we should use antibiotics where we need to, but generally speaking, I think vaccination is a really big part of how antibiotic resistance needs to be combated, because it reduces the burden of disease, which therefore enables us to not use as many antibiotics in the first place. I was going to briefly do some stuff on empathy and vaccine conversations and how to have vaccine conversations, but I thought I'd stop there and ask if anyone has any questions at this point. Because I realise I've been talking for 30 minutes and that was it was 30 minutes of questions and a 30-minute presentation. Tim.
Thanks, Jamie. It's a really, really excellent presentation. I just wonder if you had any views on, I believe in Australia, if you haven't had your child vaccinated, they can't attend school. There's a sort of mandatory vaccination component there. Do you think that has any effect? Do we know if that's effective at all? Do you think that has any role at all to play?
I mean, I can look and see what happened in Australia, but my initial thoughts are, in the UK, when you say you must, people almost dig their heels in more and say, why are you saying I have to? No, I actually think that sometimes when you do things like that, it can really make people just dig their heels in even more. I don't think it's the answer. I think that it depends on what kind of context you're looking at as well. Like if there are particular communities where children may become more isolated as a result of not going to school because of religious decisions around vaccination leading to homeschooling, there's actually additional risks to the child that aren't just to do with their infectious disease risk by excluding them because their parents won't bring them in. And I think when you see things like the raw milk, deaths in Florida, most of the kids who are dying or who have really serious side effects are under 10 and they don't have a choice in who their parents are. So I would say I can see why it might be necessary if vaccination rates fall. Fortunately, in Warwickshire, for MMR at least, we're close to 95%. It's really not far off herd immunity. But of course, there's always the risk. Every year we have to maintain that and keep it up because one imported case could spread across different communities. Mike Wells?
Thanks, Jamie. Yeah, it's just I'm of an age where we used to get jabbed at school and take the note home saying we'd had the jab. Just very different world that it used to be, and I don't know how we sort of slid away from that. I mean, my daughter did lots of school trips to sunny climes in the equatorial regions, and has got a list as long as your arm of vaccinations that she's had. Don't understand it.
Yeah, I think that it used to be a lot more we would just do, and now we don't so much.
Yeah.
We ask. Carolyn?
Yeah, just going back to the resistance of antibiotics, it's a really serious situation, and I don't think it's being pushed strongly enough to be so serious, because if antibiotics do not work, there are lots of things which are going to be rampant. So how to get more understanding? I mean, do GPs understand fully, sorry Tim if I'm insulting you, that antibiotics should not be given out so freely, and how to get into the population consciousness the fact that you shouldn't ask for antibiotics unless it's absolutely necessary? I do think it's a really serious situation.
In response to your question, I think GPs are aware, but we've got an antibiotic kind of working group which meets quarterly. So if there is anything in particular you'd like to raise with general practice, we can take it to that. The next one's on the 14th of October, so I think that's next week on Tuesday. But yeah, they definitely are aware. I think it does depend on the practice though. And in terms of raising awareness, I've got one project that I'm working on at the moment where I have resident doctors, so junior doctors who come, but the most recent ones went into primary schools and they gave education sessions on antibiotic resistance to years 4, 5 and 6 to 960 children across the area, and we're hopefully going to expand that into secondary schools for my next intake, which will be from December to April. So I'm very aware that there isn't a lot of good understanding about AMR out there. I think that it is really important to get it out into the public. Sorry, Paul.
Yes. Do you see any fatalities from measles in adults?
Well, I don't think we've had many cases. Frankly, I haven't heard of any adult cases. We had a child die in Alder Hey, didn't we? Yeah. So that we've definitely had a death of a child from measles. But I think in terms of deaths from measles, it's probably more likely to happen when you're young because of the inflammation risk. But again, it's about that secondary infection. It's very unlikely that an adult will make it into adulthood and not have been exposed to measles because it is so infectious and so many people are vaccinated. I know that chickenpox can be really, really dangerous if adults get it, because if you don't have it when you're a child, that can be a lot more severe. Theckley, sorry, do you have a point on that, or is it unrelated?
I had a different point about the antibiotic resistance, actually, I wanted to come in on. But
Okay, but sorry, Paul, to go back to the fatalities in adults, I've not heard of one, but that doesn't mean that it hasn't happened. It definitely hasn't happened in the UK, to my knowledge.
And is there going to be a vaccination programme now for chickenpox?
So the NHS England have announced that from January, they're going to roll out the MMRV. So they're currently changing the schedule. So at the moment, or the way it was you have one MMR at age 1 and then another MMR at age 3. But they're changing it. So now it's going to be one MMR at age 1 and one MMR at age 18 months. So they're bringing it forward because people are more likely to bring their children in for their vaccines the younger they are. I think there's something about the ease of which you can get to appointments as well, like when they're a younger age, people are more likely to prioritize it. But from January, that MMR jab will be MMRV, so that will include varicella. So from January, we will be having at 12 and 18 months of chickenpox vaccination included with measles, mumps, and rubella.
Good, thank you.
Okay, Theckley, so antibiotic resistance.
Yeah, thank you. So I just wanted to just come back on Carolyn's point, actually, and just say, yeah, absolutely, antimicrobial resistance is it's the slow, they call it the slow pandemic. We are already seeing these sort of cases where we've got no antibiotics left, and we know that not many new antibiotics are coming out in the pipeline. Part of that is discoveries and the amount of money that's needed to invest, and we know a lot of the pharmaceutical companies have just stopped developing antibiotics because they don't make the returns on them to make it worthwhile for them to develop them and research them, because they end up being short courses that are often reserved and so on. And speaking to colleagues in the pharmaceutical industry, obviously vaccinating against viral infections is so important because you're not going to need the antibiotics for a secondary bacterial infection in the first place. But the other thing is, because they're not looking at new antibiotics, what they are looking at, for example, some of the bacterial infections we see, Pseudomonas, where we can run out of antibiotics in those situations, they are looking now at vaccines. They're developing vaccines against some of these multi-resistant bacteria that we see. So it is something that we could be using more in the pipeline. That might then become our only option if the antibiotics aren't working. So yeah, absolutely. And just to say, we do raise awareness both in hospital and the community. Every year the World Health Organization has the antimicrobial resistance awareness week, and it's on the 18th to the 24th of November every year. So we use that as an opportunity to kind of raise awareness, and quite often there's something in the national media about that to sort of help sort of put that information out there so people do know. So, you know, the general public know, as well as clinicians, as well, you know, everybody, because it affects us all in the future. If we run out of antibiotics, we'll be back into the sort of pre-antibiotic era again.
Yeah, thank you very much for that. Thank you.
Thanks, Theckley. I think that it's terrifying, the thought of it, like having so many women die in labour or children dying of scarlet fever. People just don't know how bad it could be. Honestly, it could be terrible. And when I think about, again, I come back to Florence Nightingale, I'm like, you know, they were just in a place where nobody even knew how many people were dying from what reason. She just came in and started taking records, and that was enough to completely turn everything on its head around what we knew about infection prevention. Tim?
Yeah, just another comment about the antibiotic resistance. It is quite complicated in general practice, and there is a lot of factors involved there, and a lot of pressure often put on GPs to prescribe when it probably isn't clinically appropriate. But we are relatively privileged in the UK in the fact that antibiotics remain prescription-only medications, whereas other parts of the world, you know, you can go and buy them if you want them. And we know that, you know, infectious diseases are global. I mean, COVID demonstrated it. So, and the other area of antibiotic use, which is, I believe, of concern, is use in agriculture and animal health. And if the Americans are filling their beef cows with antibiotics to increase growth, we do have a problem. And I don't know, Jamie Ray, if you've got any comments about or takes on the use of antibiotics in animal health.
Well, I can tell you what I know. I did my dissertation on pig farming in America, actually, so I've got a lot of experience thinking specifically about pigs, not cows. But the UK's position is that we have changed the rules around what antibiotics can be used in farming, and they have gone down significantly. But my feeling is that they've gone down to what I would say is still an unacceptable level. But because they can say last year we've gone down by 100%, they're like, oh, we've done great. And I'm like, we're probably using way too many to begin with. And I don't know if I think that's far enough. But again, we only have a very limited number within my patch. I think we've got one pig farm, which has got about 6,000 pigs on it. And then there's, again, some large bird facilities. For me, there's something as well about the kind of waste management element of it, because those animals will be secreting antibiotics in their feces, and then that is then spread on crops, and then that is used in the general environment. It can filter into our rivers and so on. So I do think there is more that needs to be done to understand the full extent. But the problem with any kind of environmental epidemiology is that the health impacts are so downstream that it's very hard to have a direct causal relationship. And I think in particular for me, when I think about the waste from chickens and the potential for, things like salmonella or E. coli to be living in their feces, and then for them to be exposed to antibiotics through that route, it is very concerning. But I mean, again, chickens now are only living about 30 days, 40 days before they're killed. It's a very fast changing industry in terms of industrial meat production, but I would advise everyone to try and stick to organic if you can, or free range at least. Liz Coles.
Thanks, Jamie. No, I was just actually going back to what you were saying about people not understanding the consequences of going back and the antibiotic resistance. My father was born in 1933. His mother had TB and he caught it. So he was in hospital for about a year, age 3. And of course, this was before antibiotics. He had a sort of pre-antibiotic. And so, of course, he was growing at the time. So he ended up with a collapsed chest and spine. When I was a child, I mean, the popular thing, which was an insult at the time, which was hunchback, which you don't use now, except it's gone into children's cartoons and stuff like that. And he had reduced lung capacity, and it affected his heart all his life. But you just don't see it now. And when he was older, when he was in hospital, and he used to go to hospital a lot, he quite often asked if students could examine him because it was so rare. And we are still getting vaccination for children, which hopefully will prevent what happened to him. But that is in my living memory. But I would debate how many people in their 20s or 30s nowadays have actually seen that or grown up with that, as I did. And so, again, it's another sort of loss of race memory, isn't it? You're not used to it. So you don't actually live with the consequence of not having the antibiotics or the vaccination, because it didn't happen anymore. But we could well start seeing it again if you can't treat TB with antibiotics, or it gets into the younger part of the population.
TB is an interesting one, isn't it? Because it's in everything. In Warwickshire, there's some interest as well from the farming perspective, because there's bovine TB and badger TB as well. But in terms of the people with tuberculosis, there's actually a medication shortage at the moment for the antibiotics needed for latent tuberculosis. And in terms of international funding, since Donald Trump's come to power, the National Institutes for Health have cut the funding for HIV and for tuberculosis research. So I think that tuberculosis is something that in the next 3 to 5 years, we're probably going to see a lot more of globally, just because there's a lot less treatment happening in non-EU countries, let's say, for tuberculosis. And the people who are most likely to have antibiotic resistance are those who have already got pre-existing infections and where antibiotics have a cost implication. So again, where people will feel better, they won't take their antibiotics anymore because they feel better and they don't think they need them. And maybe they'll give them to a family member who might also be ill. I think that that's something we're going to really have to keep an eye on for the next 5 years. Tim?
Sorry, yes, just on the TB point, obviously we've seen HIV has sort of impacted TB. We've seen a bit more connected to that, and of course we've got large numbers of people now, or increasing numbers of people who are going to be on immune suppressant stroke modifying drugs for many years for various conditions, including cancers. So that again, TB has always been the opportunistic infection, or jump in there given the chance. And we've also got increasing population mobility as well, with sort of refugee and asylum seeker populations as well. I mean, the upsurge in TB after World War II was largely connected to large volumes of people in relatively poor health moving around Europe. But TB is always there and will pop up given half a chance.
It's also interesting because only 5% of people who are actually initially infected develop active tuberculosis. So most people won't get active TB even if they're exposed to it. So again, it's like there can be a bit of panic whenever we have a TB case, because we'll think, oh, it's going to have traveled around, but actually a lot of the time it doesn't transmit as easily as you would think. I think that the point about people moving around is valid, although I would say more of that to come. When you think about what's happening around increased flooding globally and increased global weather insecurity, the one thing I think about in particular is Bangladesh being below sea level. Like at the moment, people are able to live in Bangladesh, but within 5 to 10 years, the risk of extreme flooding is going to significantly increase. We're going to see a lot more people who are going to be refugees in the next 5 to 10 years than we are right now. And also at the moment, the majority of refugees from conflicts such as Syria all end up in Turkey. I think something like 80% of them are all still in and around the region that they came from. But it is a challenging situation that we find ourselves in, because again, with tuberculosis, I think we need to focus on getting people to screen for latent TB, which can activate when they're then stressed later on or when they're run down. So again, people who don't feel ill aren't likely to seek treatment. So again, it's about that awareness and letting people know that by getting things like latent tuberculosis screening, they're protecting their community and their family who they live in close proximity with. So yeah, but I do think tuberculosis is going to be very challenging in the next 5 years. Okay, we've got 8 minutes left. I had some more slides, but I think I'll just leave it as more questions if anybody. I was going to say, actually, Theckley, on your point about the other vaccinations for recurrent infections, my registrar has just done me a literature search on UTI vaccines, which I might send you for interest's sake. But at the moment, they're not as advanced as we were hoping. We were kind of like, oh, this sounds really exciting. And then we went and looked into it in more detail, and it was actually not great evidence, and they're not very well rolled out at this point. But hopefully in the future, we will be able to vaccinate people who have recurrent UTIs.
Yeah, I know there's been some interest by our local urologist to look into them further. So I'd be, really interested to see that. Thank you.
Does anyone else have any other questions or thoughts? I mean, I find vaccinations really inspirational. If you think about how we've come from a point where they did variolation, which was prior to Jenner discovering cowpox, where they would actually take smallpox scabs and blow it up someone's nose. And the fatality rate was 1 to 2%. So from being variolated, you would still 1 or 2 people out of 100 would die. And it was still better than having smallpox, where 30% of people would die. We've come a really long way from that. And I think that a lot of the rhetoric, particularly coming out of America right now around multiple vaccinations, is going to be really challenging to address. So only this week, Donald Trump has said that he thinks that they need to split the MMR into multiple vaccines. There's no provider for that. No one does it. People don't come to the appointments as it is. That means that you'd have an extra 6 appointments. The reason we vaccinate children when we do is because it's, the quickest, easiest way to give them as much protection as possible as soon as we can. And I do worry that because it's English language as much as anything else, is going to start really influencing our conversations with parents in particular. Tim?
a completely different subject, public health in general. I mean, obviously, you know, everyone's awareness that public health needs significant funding and support came way to the fore with COVID. Where are we with public health in terms of funding and support for the service in the UK?
Well, so there are a number of different what we could call public health. I think public health is everything, but I'm biased. In terms of the public health grant, we have a grant which sits with the local authority, and there are certain things that the local authority have to do as part of government legislation. One of those is drug and alcohol treatment services. One of them is sexual health services. The other one is healthy sort of lifestyle services. But the way that we're providing that is changing quite significantly in the near future because of the introduction of new technologies such as Manjaro and Ozempic and all of the weight loss drugs, which means that people's relationship with food is changing very rapidly. And then also the fact that different groups of people have different requirements, don't they, for what they would want in terms of a healthy lifestyle service. Is it something that's online? Is it something that's face-to-face in communities? But in terms of wider public health funding, there's also all of the population health management work that's going on, where they're trying to look at GP and hospital data together to be able to try and create a better pathway view of like when people end up needing hospital later on. So it happens, it's continuing to happen. I do think that funding is important for public health, but I mean, again, in terms of our local need, it comes from for the council, it comes from the Department for Health and Social Care. There is a lot of questions at the moment about how it's not very equitable across the whole of the UK. So at the moment, the public health grant could be very different between Warwickshire and, say, I don't know, Worcestershire or Huddersfield. So they are doing some work on trying to figure out what it is that causes that variation in funding. But again, the postcode lottery, it's very difficult, isn't it? The other job that I have to do as part of my work is provide public health advice to the Integrated Care Board. So we do things like commissioning policies for aesthetic procedures or for grommets or, you know, any of the many different things that they write commissioning policies for. One of the most controversial ones at the moment is the ADHD policy, which is being, I think, challenged legally because they're not giving anybody over 25 a diagnosis of ADHD at the moment unless they go through an individual funding request. And the reason for that is that historically, children's have to go to one specific service, which has a waiting list, which is just completely ridiculous. Adults could go to any qualified provider. So basically they could go to anyone and then claim it back on the NHS. But that meant we were in a situation where the adult demand for ADHD diagnosis had gone up by something like 300% in 1 year. And children were on a waiting list that was just getting longer and longer. And we know that the interventions around. So again, I would say that's also public health information because, you know, it's preschool autism diagnosis, how you get kids support into their education settings so that they don't have negative problems later on. There's just so much going on all of the time. But the ADHD and autism stuff, that's also very politically controversial, isn't it? You think again about some of the things that Donald Trump's been saying about paracetamol use in pregnancy and autism. I do think that that's going to be a really interesting challenge because the demand is going up, and it is because we're better at picking it up from younger ages. But again, early intervention for children, it's going to result in much better outcomes for them in the long term. I would argue that perhaps people who are older, who have been functional for a long time, don't need that diagnosis in the same way that a young child would do in order to get, you know, the reasonable adjustments they need into their schooling. But again, it depends on a completely case-by-case basis. There are some people who have really significant health needs as a result of neurological disorders. So
yeah, great, thanks.
Okay, well, we've got 2 minutes to go. Does anyone else have any other questions? But thank you all for listening. I mostly a sea of letters, but I can see Theckley and Paul and Tim. Thanks for having me. Oh, Mike.
Yeah,
yes.
Oh, sorry, Mike. Yes.
Just before you go, we need to get you down to Shipston to see the results of all your hard work before you went on maternity leave.
Yeah, I really want to come and see Shipston.
The Health and Wellbeing Hub is fantastic. Thanks to you.
It is. Oh, I'm so glad to hear it, Mike.
That's brilliant.
Duncan, I did ask Duncan. I was like, how do I get there? I was like, who do I contact? But the GP practice isn't in there anymore, is it?
It's going to be in from the end of this, maybe November. It's not far away. They've got 11 consulting rooms in there. So
fab. No, that's great.
So yeah, it's good. Yeah.
Well, thank
I'll
you,
get you an
everybody.
Okay, so
I'll get you an invite.
yeah, thank you very much, Jamie Ray. It's really excellent presentation. I'm sure everyone got a lot from that. I certainly did. So if I just draw the session to a close, if anyone has any other questions, they can email those to the membership address at Swift if they want to. And just to remind people that the video of the session will be available on the Trust's YouTube channel, and that we have one or two other sessions arranged, the next one being on the 6th of November, symptoms and treatment of long COVID, and another one regarding keeping moving and staying safe at home, but we haven't got a date yet for that. So we've got another two coming up. So if perhaps we'll just draw the session to a close now. And again, Jamie Ray, thank you very much. That was excellent. Brilliant. Thank you very much.
Thank you.
Bye.
Bye.
Thank you.